different ways of looking, all are okay.
Dr. Desai here. Nice talk. I just wanted to find out this 72% you said were on subtherapeutic dose, no? So what were the determinants? Why was it in that particular population of nearly 80% that they were on subtherapeutic dose?
Sorry, say again.
Could you identify the factors that determine, so that if those factors are there, then we need not do the test? About 80% you said were suboptimal dose, no? In your study. So what were the determinants? What were the factors? Was it the age? Was it the disease state?
Okay. So we can see these factors.
Yeah,
so we have low BMI, male gender, high baseline CRP, low albumin, presence of anti-drug antibody, and this thing. So these all increase the clearance of the drugs. That is why many of our patients are quite sick actually. So they tend to have lower drug. Also, we have this concept of three things. One, that the inflammatory load is high. So the whatever drug we give is immediately neutralized. Second thing is the reticuloendothelial system chews the drug, shark sieve, and there is more passage of drug in the stool because of inflammation. So that is why our population probably represents sick, like what Dr. Ananthakrishnan said, that we tend to go on the first we try 5-ASA, then we try azathioprine, and then we try. So by then patients are often sick. That's why 80% of our patients had low infliximab level.
But if you improve the nutritional status, you think if you improve the nutritional status of these patients, then maybe you can optimize the dose at the current dosage that we are giving? Suppose you improve the albumin and you improve the nutrition of the patient, then do you think the subtherapeutic percentage that you're getting would improve and make them more optimized?
Yes. So if we optimize this earlier, then if you see the second, this one, the low level of the drug itself predisposes to antibody formation. If we optimize earlier, then we are going to have lower loss of response.
Nice talk, thank you.
Sir, I have a doubt. Can I ask? So I have two questions, sir. First is a very practical question, sir. What is the ideal time during the maintenance therapy that we should be sending these samples for therapeutic drug monitoring? For example, if a patient is on infliximab every 8th week, so when during the maintenance therapy should we exactly send the sample? The second doubt is, so when a patient is having refractory extraintestinal manifestations and he has improvement in his bowel symptoms, do we still do a reactive therapeutic drug monitoring? Does that help in that case? Thank you.
So the first question is when to do the monitoring. So as I said, that initial guidelines were that you do it during the when patient is not responding, that is reactive. So if the patient is not responding, at that time you would do it. If you are thinking about proactive, at the end of, so when we are giving the first maintenance, at that time we should collect. Some people would do it at 14 weeks. So any of these two is okay. And the second thing is about extraintestinal manifestation. The first biologic may actually control it, because we know that infliximab, adalimumab, vedolizumab, all are acting against the extraintestinal manifestation also. But sometimes it can happen that the drug can only control the bowel symptoms, and you may have to use another drug for extraintestinal manifestation. That is also possible.
Thank you, sir.
Other questions? Thank the speaker on saying.
Ashwin also.
Ashwin, yes, sorry. Sir, the questions for the first speaker, the paradigm of shift of evolving treatment. Questions are invited.
Thank you, Dr. Devendra Desai, for that nice lecture. Now I think we've just started doing therapeutic drug monitoring in Chennai, but antibodies we are not doing. So just trying to get those levels, and some of them are low, but then to decrease the frequency is another problem for us. So probably. So Dr. Ashwin, I just wanted to know, because diet, I think you didn't mention, there's a lot of thing where you talk about anti-inflammatory, CD, Crohn's diet and all that, which is now coming up a long way. So does it keep changing during the inflammation, during the exacerbation, then you come back, or what are the things in diet? We just want to.
So the question is, how do you integrate diet with, like, at which phase of the disease do you integrate diet and what changes that you do? So I'm sure that's the case here as well, that, this is probably the most frequent question that we get from patients. They don't really want to hear about the biologics, but everybody wants to know what they can eat. And it's a difficult balance, because I think you also don't want people to get so obsessed about what they're eating that then impacts their quality of life. So I think I spend about 10 minutes talking to every patient on diet and what the role is. In general, so pick a diet that you think you can sustain, because I think you need to be on the diet for about 4 to 6 months for there to be benefit. There's no point in you doing a diet for 2 weeks. That's not going to be the answer to anything. So if you think you're not going to be able to sustain the diet for 4 to 6 months, then that's not even part of your treatment. And in most patients who are very reluctant to start biologics, I tell them that you need to do both together. Because I think if you tell them just that diet is not going to work, you get started on the biologic, that's going to be enough, they're going to go to the next person who tells them diet works, and they're going to do just that. So I'd much rather they stay with me and accept both biologics and diet. And the goal, I tell them, it's sort of like how far away from the edge of the cliff you are. Like, I think the biologics help you heal more so that you can be a little bit more relaxed with your diet. So it's just sort of, and once somebody has gotten in remission, the goal is for them to eat a healthy but unrestricted diet for the most part, right? So if you eat a Mediterranean style diet, make sure you have enough fruits and vegetables. Don't eat a lot of processed foods that are rich in sugars and salts. Those are all, I think, very important from all kinds of health, but they're particularly important for IBD as well. And that's sort of they don't need to be on an exclusion diet as long as they're within that broad framework once they're in remission. But if they want to use diet to attain remission, then use one that there's evidence, whether it's the CDED or an autoimmune diet or an anti-inflammatory diet.
Thank you.
So one, I missed and corrected, but in India we don't have insurance for the IBD patients. What is the state of affairs there? Are we having a regular, in our schemes, CM schemes, IBD treatment does not have any insurance component. It's a costly drug for the infliximab and adalimumab. I started adalimumab first time in Tamil Nadu in my government hospital. So how is it in US West?
So, I mean, cost and insurance is still very much a problem there as well, though slightly less than here. Insurances, where we run into a problem is insurances tend to decide which drug to start. For example, most insurances have adalimumab as the first biologic. So if you need to start somebody on either Vero or Isgtnc-2022 or something as the first agent, it's hard. It's getting easier, but that is the barrier. The same as here, patients on the extreme. So a lot of older patients are on government insurance there called Medicare, and a lot of the injectables are very expensive for them, so they're not able to actually. So if somebody was over 65, I would rather start them on infliximab than adalimumab, because their out-of-pocket costs will be very high with adalimumab. So yes, there's insurance, but I think there's just a whole different set of challenges there that make it difficult to get access to. But it's gotten better in some ways, that we're able to start it earlier. And before, I would have to show somebody failed 5 ASAs and azathioprine, and now I can get first-line biologics in many.
Because why this question was, because it's not a question of 1 day or 1 week or 1 month. It's going to be lifelong, some people say, for biological. So it is going to, you are going to sell the property and settle everything. So that's the problem, economic problem.
Yeah.
It's totally out of the gambit, but this is a practical valid point, I thought.
Yeah, No, I mean, I fully agree, right? That's why I think the field is sort of, it's a little bit silly and disconnected how, you know, if all meetings in North America and Europe are talking about combination biologics and using biologics sort of early on and doubling dose and tripling dose, that's not going to be the sustainable solution in most